First of all, I just want to say what an honor it is to be here today and to have all of you come to Boise for this regional conference of distinction on suicide. I can't tell you what it means, really, from a number of points in the opportunity to bring this all together. The committee that formed this over the past couple of years and has continued to be so involved in our local and regional support has been just phenomenal. So thank you to all of you for helping get this conference underway. My name is Stuart Wilder. I am a survivor of suicide, as is my wife and my son, as we lost our son Cameron, a 17-year-old, on September 8th, 2013 to suicide. I also serve as the president of Live Wilder Foundation. I'm also the president of the Idaho Suicide Prevention Coalition, and I'm a member of the Idaho Suicide Prevention Council. I'm going to give just a little bit of a background on the conference for everybody. There's information in your programs. This conference started up back in 2014. This is the third annual conference that we've had. Originally, the conference was titled Zero Suicide Inland Northwest and was held at Gonzaga University, which really pulled in most of our Washington friends and neighbors, Idaho and Montana. And thanks to the leadership of a woman named Marnie Lombard, who is not with us today, she had other commitments, got the conference up and running and really put it on a great path over the past couple of years. The decision this year from the committee was to expand our regional reach by bringing the conference to Boise in order to include more of our western neighbors who are really fighting the same battles that we all are in the Pacific Northwest around suicide, which is also, includes Washington, Oregon, Utah, Nevada, Wyoming, Montana, and Idaho. So we felt this, Boise is a great city. We're very proud of it, but I think it's also a great location, sort of central to where we are. We are also very located centrally, I think, for our Native American populations as well. So we're really pleased to have this in Boise. We'll see how the conference goes and evaluations. We'd love to see the conference come back next year to the same location. The goal for this conference really is to learn from each other, to hear what's happening, especially in other states. As there's so much going on in each of our own communities. One of the things we want to particularly stay away from is trying to recreate wheels, that kind of thing, and new programs when there are existing programs. You'll hear some great legislation, different things that other people are doing. So it's really bringing people together, listening to what's happening. But the big part is to network with each other, take something back to your communities that you learn from this conference, but mostly just to get to know each other. And I think that's really been the strong point of this conference. And one of the key differentiators of this conference is this, we have both a professional track and a lay track. So we try to open this conference up so there's content for everybody in the community to gain from. Being that the conference did move to Boise, our governor, Butch Otter, has signed a proclamation for the event. So there's a copy of it in your program, but I'll just go ahead and read it. So we are pleased to have some recognition from our state leadership. Whereas the annual conference on suicide at Gonzaga University, formerly known as Zero Suicide Inland Northwest, has been renamed the Western States Conference on Suicide, and has moved to Boise State University for 2017. And whereas education and training are a core component of this conference, including national, international, and regional speakers to help combat the stigma around discussing suicide and provide tools for states in the West to adopt and share. And whereas the conference provides an opportunity for critical evidence-based training to improve skills in the identification and treatment of suicidal individuals and those with related mental health issues. And whereas the conference offers an opportunity to share information on education, legislation, and other topics pertinent to suicide prevention in the West. And whereas in the United States, one person dies by suicide every 11.9 minutes, with 44,193 deaths by suicide in our country during 2015. And whereas in our country, suicide is the second leading cause of death for 15 to 24-year-olds and is the 10th leading cause of death for people of all ages. Now therefore, I, C.L. Butch Otter, Governor of the State of Idaho, do hereby proclaim June 23rd and 24th, 2017 to be the Western States Conference on Suicide in Boise, Idaho.
Creator, we're asking in this conference that you guide us. You take away the sadness. You give us the power and the tools to work with our knowledge and use it to help people find alternatives to suicide. And that everyone in this room has the strength and the foresight and the focus to be able to help people when they're identified as possibly having a problem, or the situations are such that they might commit suicide. And that we all take that power and use it in the best way we can to help our children, to help our neighbors, to help our communities. And it doesn't matter, you know, if you have the desire to look, to acknowledge that these things happen, and to not let your pride get in the way. You know, if I'm worried about something, I need to talk to somebody. I need to go next door and say, hey, do you know anybody that can help us? You know, don't think you're help us to recognize that, you know, we need to unite. We need to work together to become stronger. Creator, I want you to bless everyone that's in this room, because they're all helpers, and to give them the strength to go out and teach, to educate other people and make them aware that this is an epidemic that is very difficult to deal with. And I think that, you know, Native American people have the highest rate of suicide, and we need to have strength in our communities, and we hope that everyone here has us in their prayers so that this epidemic stops. And we'd like to thank and bless the Creator, to bless everybody that put this organization together, this conference, because we need it. We need to talk about these things. We need to put them out in the open. I know in a tribal community there's a certain amount of shame, embarrassment, and people don't want to talk about it, but we need to talk about it. We need to share it. This is what I saw, and this is what I felt, and I didn't realize that this was something I should have taken note of. But Creator, bless us and bless the people that have made this conference possible, and make everyone take home something valuable from this conference. Thank you, Creator.
Because this is a continuing medical education, conference or program, and some of you are receiving CME credits and CU credits for this, we're obliged to give you financial disclosures. And I've tried to summarize my financial disclosures on this slide, and as you can see, I have many. In that my university funding has been provided by almost every company involved in medical and psychiatric research, many of the federal and other agencies involved in this, and I also have patents involved in medical research. I don't own any stock, nor have I ever owned any stock in any pharmaceutical company, but I do own some stock in some technology companies that are involved in assessment and care. And I also am the copyright holder of books and assessment instruments in the area of suicidality summarized on this slide. So you probably shouldn't believe anything I tell you. I will try to be fair and balanced and do the best I can to steer a middle ground. One of my patients came to me one day and she said, "Psychiatrists are interesting people." She said, "You can go and talk to your psychiatrist about violence, chaos, mayhem, rape, plunder, and they sit there like Buddhas, and they don't flicker an eyelid, and they're calm as can be. But the moment you start talking about suicide, you can see the fear in their eyes and the anxiety on their face, and their little brains are spinning, and they're no longer listening, and they're trying to think, what do we do to get out of this mess we're in? We got to do something urgently." They are the people appointed by society to help us. She said, how can they help us if this is their universal reaction? We have to talk to someone about it. And then she went on to say, she said, they think they are interviewing us, but really, we are interviewing them. And when we see this reaction, we know we've come to the wrong place, and it's time to talk our way out of this emergency room or health center and go find somebody we can talk to. So that's the dilemma. It's the most backward area of psychiatric research. We have made, at least until very recently, very little progress in the area of suicidality in our understanding of it in the last 150 years. We're essentially working off models that are 150 years old. There are no approved treatments for suicidality by the Food and Drug Administration of the United States or any regulatory agency in the world. We don't have all the answers. In fact, we don't have many answers at all. But we have to start. The problem is when we start to do this research, we go to funding agencies. We say, we want to do a study on suicidality. They say, no, no, no. We go to the institutional review boards of our universities or our hospitals. We want to do a study on the treatment of suicidality. Well, let's see what you want to do. Oh, no, 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 you can't do that. So why do you not want us to do it? It's too dangerous. People can die by suicide. And then we say, hold on a second. Am I hearing this correctly? Imagine we went to this cancer specialist and we tell them, no more studies on lung cancer or pancreatic cancer. Why not? Well, because people die from those things. But you can study basal cell carcinoma, you know, for people lying out in the sun too long. That's okay because that's safe. Or we go to the cardiologists and we tell them, no more studies on myocardial infarction, heart attacks. No more studies on congestive heart failure. And they say, why? People die from those things. But you can study people who get a little flutter in their heart occasionally. That's okay because that's safe. Say, what are you thinking about? We need to be focusing on doing studies and proper medical research on the areas where people are dying. And in psychiatry, the major source of mortality is dying by suicide. So we need to stop this nonsense and get with solving the problems of suicidality disorders, plural, in the way we have solved the problem with all other medical illnesses. And that's the focus of my work and the outline of the presentation this morning, which has been put together with full cooperation and collaboration with Jennifer Giddens, who's my co-author on many books and papers and workshops and so on, posters that you see outside. Jennifer is here with us today and will be happy to talk to any of you at the posters to fill in more detail. So I want to acknowledge her major contribution. She was going to give the middle part of this presentation, but we decided in the interest of time it was more efficient if I just went through it quickly. First, I'm going to talk just a few quick slides on the numbers. What are the facts? What are we struggling with? Then what's called the phenomenology. Now, this approach to medical research essentially says, stop having theories. Stop trying to explain things away. Just observe what's right under your nose and describe it accurately. And if you're careful enough and measure all these things precisely over an extended period of time patiently, the data will start to tell you the whole story. But jumping to premature conclusions is dangerous and usually misleading. So that's been our approach. I'm going to say some words about the genetic research that's going on in suicidality, some words about assessment and tracking, and then some of the new developments in medication treatments. There are 12 different companies that currently have specific anti-suicidal medications in research development. I don't mean antidepressants. I don't mean mood stabilizers. I don't mean antipsychotics. Specific drugs targeted to treat quickly and efficiently suicidal thoughts and behaviors. We'll talk about that at the end. So, the facts, you've heard some of them earlier mentioned. It's the 10th leading cause of death from all causes in the United States and the 15th leading cause of death from all causes internationally. Even with all the wars and the terrible things that are going on everywhere and the diseases in developing countries, it's still right up there at the top of the list. It's the second leading cause of death among 15 to 34-year-olds. 42,700 plus patients died by suicide in some of the most recent data. This number is going up, not going down. Clearly, we're not doing something right. The numbers are going up, not going down. And there are 25 times approximately more attempts than deaths, which means there are almost 1 million documented attempts of suicide every year in the United States. And both the numbers I showed you on the last slide and even these numbers, we all know it's underreported. The numbers are clearly much higher because people are trying to play ostrich. During the short time of my presentation, 45 minutes, there will be one death every 40 seconds worldwide. That means 68 people are going to die by suicide during my presentation. And during that same time, there's going to be one suicide attempt every 1.6 seconds. That means 1,687 people approximately will make suicide attempts just during the short time of my presentation.
So people who are exposed to a suicide are kind of fall along a continuum. So those with any connection to the deceased, so any student in a school where death has occurred is at higher risk. Close friends and family are at the highest risk, but that school community is impacted. It may be a rival football team that's impacted. It may be the Boys and Girls Club is impacted. So we have to look where those tentacles lie for that youth and determine the response from there. We have a rural community along the Columbia Gorge. Very close social and family ties across the river to Washington. We had one boy die in Washington, one boy die in Oregon within days of each other. They're brothers. One lives with mom, one lives with dad. So you had two states having an impact around suicide, and people knew each other from across the border. So we look beyond that one community in Oregon, which is what we care about, right, to the Washington community that was equally as impacted. So there are people who react to a suicide, and their grief is what we probably all consider mild. There are people who have distress in a moderate sort of way, and then there are people who will adapt to their grief, adapt to that new normal over time. But there are people that we need to watch over time because their grieving becomes protracted, and it includes diminished functioning. in important aspects of their lives. So I found this graphic, which you probably can't read all the little type, but this comes from Australia, and they did mapping around who is most impacted for a suicide. So geographic proximity is a factor. How close physically are they to the person who died? So they're in the same school. They're in the honor society together. They're on the same football team. Geographic proximity. Now, tough part here is that social media is pulling us all so close together. We need to include that in geographical proximity. They're in your living room. They're on your phone. And kids are learning about suicides from a whole host of countries. A whole host of high-risk groups like LGBTQ suicides will be on social media. And those LGBTQ kids who are exploring their sexual orientation in a rural Oregon community can be impacted by the death of someone that occurs in Boston or Atlanta or somewhere else in the country. Psychosocial proximity, like victims of bullying, sports team members, in the same gang, for example, family members, friends, romantic relationships. Those folks have a psychosocial proximity to the person. They have a social connection, they have a psychological connection with the individual who dies. And
The lengthy emergency department stays, I don't know who wins the lengthiest, but how long have you had a mental health patient or somebody that's waiting for an inpatient bed, psychiatric inpatient bed? How long have they? 108 hours. How, days, people are saying days, yeah. And so, you know, everybody knows, even if you don't work in the emergency department, that emergency departments are not equipped to have patients for 108 hours and days and days. That's an issue. But hopefully, you can address these issues if you can institute some best practices, because that's what they're designed to do. To reduce the stays, treat patients more appropriately. And then you have, of course, the lack of inpatient beds. I don't know, what's Boise like for inpatient beds? Horrible? Under 200. How, do you have to refer to other cities in Idaho or areas outside? Pediatric patients are hard to place. We have the same issue in Spokane. I know that, you know, we look all over the state of Washington for beds, inpatient beds available for our patients. So that's an issue. And of course, can't address that right now, but you're going to be thinking about that when you're hearing about this, right? And then generally just a lack of resources. How many people in the emergency room department are trained in suicide risk assessment or anything related to suicide prevention? One? Well, that's what we should go to your hospital. So I don't know how many hospitals. You're busy, yeah. So usually they're not, right? The people that work there. So we have the nurses and the ER techs and even the healthcare providers, the providers that the patients are seeing, aren't specifically trained in suicide risk assessment. And we know in Washington we have that mandated training for healthcare providers, and that is mandated because healthcare providers don't generally get any training related to mental health. So that's an issue. And if you don't have, you know, how many MHPs, designated mental health professionals, do you have in your area? How long do you have to wait for one? Do you have any psychiatric triage counselors, somebody that can maybe isn't specifically a designated mental health professional, but perhaps has a master's degree and can address mental health concerns? How many people like that do you have in your emergency department? If you're rural and they're smaller emergency departments, probably not very many. So that is the elephant in the room. And so with that, we're going to move forward. And this is kind of, what are you currently doing? So if somebody could just give me a brief kind of synopsis of what you do right now related to people that come into your emergency department with suicidal ideation or maybe an attempt. Let's do suicidal ideation. What happens? So maybe you can share with other people that don't work in the emergency department.
They kind of get flagged, right, as having an emotional issue right from the moment they walk in. Then that kind of signals myself or whatever of my colleagues who's working that time, one person for a 12-hour shift, and then we go and we see them kind of in order. So if there's 7 patients that come in within a 12-hour, actually 2-hour period, then you're seeing them 2 hours into it, 3 hours into it, 6 hours.
Okay, and so you have the patient come in, it's a pretty lengthy stay, they're triaged, they go back and see a provider, and the provider orders the mental health evaluation.
On the far end, we have Kim Kane. She is the program manager for the Suicide Prevention Program in the Idaho Department of Health and Welfare, Division of Public Health. We have Ann Kirkwood. She is the Suicide Prevention and Intervention Coordinator for the Oregon Health Authority. We have Representative Steve Eliason, Republican member of the Utah House of Representatives and suicide prevention advocate. We have Neetha Moni, Suicide Prevention Plan Program Manager for the Washington Department of Health. We have Dr. Teresa Humphrey Wadsworth, the Director of Suicide Prevention at the Prevention Management Organization of Wyoming, and Misty Vaughn Allen, our Suicide Prevention Coordinator for the state of Nevada. And to moderate this discussion, we have Dee Sarton. Dee is an Idaho Hall of Fame journalist and was awarded the SPAN Idaho Media Award in 2014. She's recognized as an advocate in suicide prevention and excellent reporting on suicide loss and awareness. So please help me welcome our multi-state panel.
Well, thank you, and thank you, panelists. It is so good to have all of you in one place at one time, and I want to get right to it because I know that you're all having such a energetic and great day, and you're probably going to have some questions that you want to be able to get answered as well. So they made this very simple for me. I don't even have to come up with the questions, although I'm such a curious person that I might have to throw in a few follow-up questions if that will be okay with all of you. But let's start with this because, wow, to have 6 states represented, 6 minds here who have been close to these issues, able to answer this question is very special. This is a rare opportunity. So here it is. What is the greatest challenge your state faces with suicide prevention? And Kim, if you don't mind, I'm going to start with you since I know you and I can pick on you. You're from Idaho. Do you mind picking that one up first? And then if you all want to jump in, or if you want to jump in and add something, we're going to try to make this kind of free-flowing. But Kim, would you mind starting us off? What is the greatest challenge in Idaho?
I can only pick one.
Well, let's start with one, and then we might give you time for another one. And nice and close to the mic, I think, is going to be important.
All right.
There you go.
I think I'll have to pick broadest scale, which just has to do with education and awareness. There's still so much stigma associated with suicide and mental health in general, and lack of understanding of mental health parity with physical health, that we have a long road to hoe as far as education goes and changing attitudes towards help seeking. And so it would be related to that very broad topic. And I know that one of the things we need to do to help reduce stigma is really to stop talking about the word stigma. But I want to impress upon people that education is key.
Okay, that's good. And I see a lot of heads nodding. Perhaps somebody that was nodding can jump in. Is this a common problem in all of the states or in some of the states, or has anybody conquered that problem yet? Yes, Representative Eliason.
One of the big challenges I faced in the legislature is a number of my colleagues falsely believe that talking about suicide will increase our suicide risk. It was a topic that came up almost every bill that we ran. And finally, a good friend of mine, Dr. Doug Gray, a psychiatrist at the University of Utah, provided me with an article from the Journal of American Medical Association that statistically proves it is not the case and it's actually just the opposite. So I distributed that journal and said, read this and let me know where they're scientifically wrong, and then I'll listen to you, said it more tactfully than that. And luckily, that concern is brought up less and less.
That's great to hear. What about some of the rest of you? Maybe I could pick on you, Ms. Moni, if you could tell us a little bit about your state. You are from Washington. So what's the greatest challenge you face in this effort of suicide prevention?
Yeah, I mean, my initial reaction was funding, but I think that's a challenge we all see. So aside from that, I would say one of our struggles is to have geographical diversity at the table. Our state, like I think many of the states here, the geography is very different, and therefore our approaches need to be very different for those communities. And sometimes we have a very strong participation from Seattle and King County, and other areas of the state feel left out. So one of the challenges we're really working on is to bring more people to be part of the conversation, and also that will improve the efforts that we have.
That's always important, isn't it? And I know I grew up in Pasco, Washington, so I know what you're talking about. We always felt left out. Poor us. All right, thank you for that. Let's just go on down the line, and let me ask you, and forgive me, I'm going to try to get everybody's names right here, but they're not right on the here, so that's throwing me off. Is it Teresa or Tressa?
Misty and
Misty.
Teresa.
And do you mind if I use your first names? That might be a little bit easier for me. Okay. Okay, so it is Misty. Misty. And you are from?
Nevada.
Nevada. All right. So fill us in on what your greatest challenge is in Nevada.
So I am going to say funding because Nevada, who has probably had the highest rate of suicide for many decades, if not in the top 5, we are 51st in behavioral health care for the whole nation. So that is frightening. Our workforce development is really daunting. And so we've had to come up with creative alternatives like education and awareness to defeat that stigma. I do think it is working. For the first time ever, we're out of the top 10. So still 51st with behavioral health care, but we're finally out of the top 10.
Well, my next question is going to address that, so don't let me forget. I really want to hear what you think has made that happen. So let's hear from that. And is it Teresa? Teresa. I feel funny using your first names, but thank you for allowing me to. Teresa, tell me a little bit about the situation that you see in Wyoming.
So in Wyoming, we're one of the largest states. We're about 9th largest state, but we have the least population, period. So trying to reach those few people spread out over that huge geographic area, I get it. And that has been one of our challenges historically. The other challenge that we experience in Wyoming is, how can I put this? Nobody wants to be told what to do. Right? So if you come in with your shiny evidence-based strategy, it really doesn't go over very well. You really have a lot of grassroots work to do to get them on board first and then grow it from the ground up. And then they're open to listening to what those best strategies are and how that will fit in their community. Funding, of course, is an issue. Wyoming has a mandatory balanced budget, and this last year they cut $2.1 million out of prevention, and it all came out of suicide prevention. So suicide prevention is zero funded in Wyoming right now from the legislative dollars. So yeah, we got an issue. But we have, and I'll talk about this later, some great community partners.
Okay. Ann Kirkwood, do you have a big problem in Oregon, or have you guys got it all figured out over there?
Well, I'm going to talk about funding, but I'm going to talk about it in a little bit different way. When people ask why are the suicide rates in the West so high, one of the things we often say because of sparse population and geographic distances is access to care. So one of the issues that seems to be getting in the way of access to care is who pays for the care. And so our Medicaid program in Oregon, believe it or not, is the most generous insurance program in the state that pay for things like family support after discharge from emergency departments to guide the family into outpatient care, pay for all kinds of stuff, but 60% of our people are privately insured, and they don't get any of that. And so it impinges on their access to care, and that's where really the pressure is being felt is among the vast majority of people with private insurance. And so I would say that a barrier is trying to expand the array of services offered under private insurance.
That's interesting. All right, so now that we've heard that, let's talk a little bit about the greatest accomplishment in your state in this field and who helped you get there. And I bet you, if you've had an accomplishment, you're probably anxious to share about that. So just jump in, grab the microphone, and tell us about your state's greatest accomplishment. Go for it.
I'll start.
Ladies before gentlemen. Okay, thank you.
In the last few years, what we've seen is a great expansion of infrastructure around suicide prevention and intervention. 9 laws passed around suicide prevention. The law that created my position, the law that created the requirement for post-vention planning at the county level, the law that requires inpatient psychiatric facilities to prepare discharge plans and have warm handoffs when people are discharged to the community. And there's 2 new laws this session to require that of emergency departments and require private insurance to pay for it. And the last thing is, while it was not my original desire, and I've been in contact with Washington State about this, I wanted to get a law passed in Oregon similar to Washington State's mandating CEUs for certain physical and behavioral health providers. And after a great deal of amendments this session, it looks like that bill will be signed by the governor soon, but it is not mandatory. Again, Oregonians don't like to be told what to do. It is entirely voluntary. If they take a class of any kind that they consider a suicide prevention class or treatment, they report it to their licensing board. The licensing board tells me how many took classes and what county they live in. And I have to prepare a list of suggested courses with no authority to require that they are the courses that are taken. So what went from what was a pretty tight mandatory bill that capitalized on the lessons learned from Washington ended up far less than what I had envisioned, but it's going to let me start collecting some data, and I'll be able to go back to the legislature and say, see, this is how a voluntary program worked, or didn't.
Well, that's great to hear, so thank you for that. And Steve, what can you add from Utah?
So we had a bill similar a few years ago that passed. We mandated it for school personnel as well as behavioral health professionals. We talked about this briefly during the breakout, but I sponsored a bill to create parent or youth protection seminars that parents could attend to learn about suicide prevention and depression and substance abuse issues. And the first year I brought it forward, it was deemed a mandate, and I got beat up all over that, and the bill ended up not passing. So the next year I got creative and came back and said, technically it's not mandatory. It's mandatory, but you can opt out, and the superintendent of the district simply needs to write a letter to the head of the school system for the state stating these issues, depression, suicide, substance abuse, are not issues in my district. I therefore opt out. And with that, I could say it's not a mandate. All you have to do is send a letter. That's it. And
You got away with that?
the bill passed then with flying colors, and we've gone 3 or 4 years now, and no district has opted out. So,
Wow.
I like it.
Kim?
Sure. Well, ours probably is also related to infrastructure, and we really had a great collaborative effort take place, not in this year's legislative session, but in last year's legislative session, that brought about the first dedicated state funding for suicide prevention. And there was a lot of hard work that went on from the Health Quality Planning Commission, the Department of Health and Welfare, our Suicide Prevention Coalition, the council, nonprofit partners, other agency partners, to really bring that about. And so what that did is it created our first state program on suicide prevention. It also provides sustainable funding for the suicide prevention hotline. It provides funding for school upstream ongoing wellness programs to prevent youth suicide and other risky behaviors. And then it's also paying for a public awareness campaign, which may be our first truly statewide, comprehensive endeavor. And what this funding has done from a broader perspective is allowed Idaho for the first time to take a more comprehensive approach to suicide prevention, which I believe is what's going to be needed to actually reduce the suicide rate.
Yeah. Well, that's really saying something too. So that's good to hear. So tell me a little bit about the situation in Wyoming, Teresa. What would you say is your greatest accomplishment there?
Well, one of our greatest accomplishments is really about that grassroots suicide prevention effort. We have coalitions in every county in Wyoming, which 5 years ago we had them in only half of the counties. So then taking the opportunity to meet with each of those coalitions, grow their knowledge and their skills. And now every county has a coalition. Every county has their own strategic suicide prevention plan based on their unique needs, risk factors, and resources. And along with that, we've been able to work with the energy industry. So Wyoming is very heavy dependent on coal and oil, natural gas. And so those revenue streams were hard hit the last couple of years. However, we've been able to work with those organizations to embed suicide prevention training into their onboarding process and their annual safety briefings. So thank you. So we're able to hit our young men who are highest, according to our recent stigma survey, they're high risk for their bias against suicide prevention and their bias against getting mental health care. We've been able to reach them. And of course, our middle-aged men, which I know I'm preaching to the choir, those are the ones who are at most risk for dying by suicide and certainly are in Wyoming. So it's our biggest industry and our biggest male-dominated industry. So that's been a huge win for us.
Teresa, was it you that said that Wyoming has zero funding for suicide? So any advice? I mean, Kim, we know it's been a tough sell in Idaho. I'm sure, as we just heard from you, Steve, that it was there. Any thoughts on how you get through and make that happen?
Oh, yeah. So how many of you know about AFSP? You have a local chapter? Yes, so we have a Wyoming AFSP local chapter. They do Out of the Darkness walks, which raises funds, and half of that money goes to national for research and half stays in your state for education and training. So that's one of our resources. The other tremendous resource that we have is with the Wyoming Episcopal Diocese Foundation, right? Faith community. They have made suicide prevention a priority. They are ensuring that every single one of their diocese priests is trained in suicide prevention. They're taking it to every one of their parishes, training everyone within their parish. If they're in a leadership position, they go through a longer training. And they're planning this September to take it even further and set aside one Sunday, and their entire congregations all will corporately throughout the state go through suicide prevention training together. In addition, the Diocese Foundation has set aside $100,000 just for suicide prevention training in Wyoming.
Wow. All right, great to hear that. Now, we just have a couple minutes left to hear about your state's greatest accomplishment. So who wants to jump in now? Okay, there you go.
So last year in Washington, the governor released an executive order on firearm fatality and suicide prevention. And it tasked several state agencies to do reports and be part of the initiative to reduce those numbers. And it was introduced along with our suicide prevention plan for the state. So it was timed very well. In order to be able to check off that we are working on those initiatives, we formed a Washington Action Alliance for Suicide Prevention. We have a lot of directors of our state agencies, including our Secretary of Health from the Department of Health, who chairs that. And earlier today when we were talking about, combining the folks with the passion and those with the power, that's what this is. You have people in really high positions of power, including like legislators, and then you have the people who have that suicide prevention expertise and understand these communities and demographics that they work with. And it's been really interesting. I mean, it's a fairly new group. We started in September, but it's interesting to hear the conversations that come from it. In fact, this past week, we had a meeting that focused on men in the middle years, similarly, and workplace efforts, really targeting adults, working adults. And so in the conversation, we started talking about like, it would be great if, yes, we have these high-risk groups, but also just implementing policies in all workplaces so that those who are also coping with a suicide loss know what they can do, who they can contact at their agencies. And the policy advisor for the governor, who sits on our committee, was like, oh, maybe we could just have the governor do a proclamation and kind of do just like a blanket state agency suggestion. So that blew me away. I thought we would just have to do agency by agency, individual efforts. And so to have that opportunity of like, wow, we can do that is really cool.
And having somebody on your board that has that kind of ability to make those things happen, that is always helpful
Absolutely.
too. All right. Misty, I don't want to leave Nevada out of this.
No, thank you. I think I've already mentioned we finally broke out of the top 10, and I believe for 2014 and 2015, Nevada was the only state in the nation whose rate did not increase.
Wow.
And that's with no behavioral health access.
So
It's
how
really
did you
tricky.
do it? What did you do?
I wish I knew, and I hope it's not a fleeting moment in time. I hope it's a trend out. But as I mentioned, we've been around since 2005. Our budget has decreased as our staff has increased from 1 to 6. So that means less for the communities. But I've said this time and time again, our relationships are our currency. So it's that passion. We cultivate those relationships in each community. So we don't have coalitions. We have existing coalitions for substance abuse that we've come in, and I've just learned to keep showing up, building that trust and knowing that we will be behind them no matter what their vision is for their community has made such a difference. So some of the powerful initiatives, it is lifespan, comprehensive strategy. We have a suicide committee to review suicide fatalities following New Hampshire's model. We just got our bill passed following Washington's model to mandate all healthcare providers have 2 hours of suicide prevention. That just happened about a month ago. So I'm learning from all of you on how to implement that. We have signs of suicide in our schools. So we have a staff member embedded in the Nevada Department of Education with Project Aware. So we're blending what we can offer with suicide prevention and early intervention with school-based mental health now. That has made all of the difference.
Wow.
And one last piece I'll mention is our Child and Family Services has mobile crisis now to prevent youth from being admitted to the hospitals. They just opened it to the rurals with telemedicine, but we have deferred about 85% of our youth, and they offer family stabilization as well. This program is supported by the legislature. It is growing almost to 24 hours a day. I feel that's a key piece in the healing efforts of intervention and prevention versus the punitive efforts. So I'll leave it at that.
Well, that is neat. Now, do we have some lawmakers? I heard we had some lawmakers in the audience here today. Do we have some that are still here by chance? Oh, you don't want to jump up and I don't blame you. Yeah, just Steve. Okay, so I'm going to ask you, Steve. When you were talking about relationships, Misty, I get a lot of phone calls at the television station. I'll get a lot of phone calls. People, they want to get something done about this or whatever. And I'll say, well, do you know your local legislator? Do you know your legislator? And I have to say 99% of the time they don't. And so to have a place to start is to have a relationship. And I just wondered if you'd speak to that quickly, because we're hearing a lot about working collaboratively. Certainly, I don't think at least in Idaho, these collaborations and the grassroots efforts are so important. But if you want the state to be a partner in that, then how do you do it?
Yeah, thank you. So you're pretty close when you say 99% don't know. We did a study, 97 to 98% don't know. So, so it's very important to get to know your legislator. And on this particular issue, I call it's not really even bipartisan, it's nonpartisan. Of course, it is bipartisan, but there's no reason to get into partisan wrangling over this. The solutions are basically the same. And so I would highly recommend getting to know your legislator, letting them know that you know that they are your representative, your House member and your Senate member. And if you send them an email, good luck. I'll give you a quick example. I'll look at my governmental email account as we sit here, and I've got just over 1,000 unread emails. So call them on the phone, pay them a visit in person. Even texting is way more powerful than just sending an email. You can still send an email, but anyway, meet with them. And it's one thing to say, you should do something about this. Well, I hear that every day about a variety of topics. come to them with a specific policy proposal. I want to see mental health professionals trained. I want to see mobile crisis outreach teams. I want to see this or that. And if you really want to be proactive, talk about maybe how it could even be funded, or help educate them how do you put the price on one life? I use the example that actuarial tables from an insurance company, it's millions of dollars if somebody's, killed in an industrial accident. Why don't we look at it from that way, from a public health perspective? And so these costs are very small compared to the benefit we gain. And I would the squeaky wheel gets the grease. Now, I'll get a little bit more political here. I have a physician in my area, and every election he calls me up, can I put a campaign sign on your lawn? Here's a donation. I'm not saying you have to do this, but he'll come up and visit me at the Capitol, send a note in, can you come speak with me? And, I come out and speak to any constituents that's there, but I know him by name, and he knows me by name, and he has my number on speed dial. And so the better you get to know them, the more they're going to be responsive to you.
And then maybe understanding how the legislature works too, and going and visiting some of those committee meetings where some of these decisions are being made, and kind of listening for who seems to be in tune. Would that be helpful as well?
Yeah, absolutely. You may find that the best person to sponsor your bill is not your representative or your senator, because maybe they don't know a lot about it, that's not their area specialty. Find those legislators that do. We have 4 physicians now in our legislature, and I often ask the physician in the Senate to be my sponsor of the bill, or go to a member of leadership. I had a member of our leadership who told me, I lost my father to suicide, and I instantly had an advocate. He says, tell me how I can help you.
Yeah.
And so find out who your allies are and then work with them.
Yeah. Oh, thank you for sharing that. Now, this kind of leads into this last question for this segment, and that is describe your legislative support and the need for collaborative support from your neighboring states. So someone jump in on that. Have any of you, what we just were talking about, have any of you seen that work, or do you have another strategy maybe in seeing legislative support really make a difference?
I'll take that one.
Oh, thank you. Teresa.
So in Wyoming, we've been watching our neighbors, because you guys are doing amazing work, and so we're trying to learn from you. One of our partners who's not here is Montana, and Montana has had a suicide death review team and published their results. And so for Wyoming, that's our northern partner. So we took a look at that and went, wow, wish we could get that. And so now we're going to get it.
Oh, all right. So that collaboration with your neighbor state really helps. And I bet a lot of that's going on here at this conference, I would guess. Did you have something, Misty?
I just wanted to add what's made for our bill for healthcare providers. In 2015, we passed the bill to mandate behavioral health care education and training. So we're still implementing that, and the primary health care was made as encouraged. It really got fought. But the veteran community deemed suicide their #1 priority, and those veterans show up like you cannot believe. That is the driving force. So I would definitely gather your National Guard, your veteran community to garner support in your legislature, because they can't. We even had a legislator say, I dare you to oppose this out loud. And it was hilarious because the room was so full of passionate and painful stories.
Yes, please, Steve.
So as a legislator myself, I'd like to second that motion. Last session, we had the first AFSP Advocacy Day on the Hill, and I attended their meetings in D.C. and got the idea that something Arkansas had done. So I arranged with a large thrift store in our state to acquire approximately 650 pairs of shoes. And then one of my colleagues in the legislature is a general in the National Guard, and I said, can I get, I can't remember the exact number, I think it was 120 pairs of combat boots. And right in the middle of the session, we put all of those shoes on the steps of the Capitol and put the combat boots right in the middle, and then we had soldiers guarding them during the exhibit, and it made the front page of the headline, and we said, these shoes represent every person who died by suicide last year, and the combat boots represent the veterans who didn't die in the line of battle but died afterward by suicide. And it was very powerful, and that all of the bills that we ran last session pretty much went through unanimously.
Wow. And now I would just like to speak to that just as a media person too. That was a powerful visual that could be absorbed by a large audience quickly, which works very well for television or even a picture in the newspaper or on social media. And I think that's one of the things that's hard with this topic, and Stuart and I have had this conversation. It is a difficult topic for us to cover because in television, for example, we're a visual medium. We need pictures, and how do you do that? What do you do? So that's a great example of how you can create that visual that is very effective. All right, so finally, and this quickly, please, any other collaborative support with neighboring states that we should mention before we leave this topic? Kim?
Yeah, I just want to mention collaboration in general with other, not just neighboring states, which is wonderful. And you mentioned Montana's suicide mortality review team, which is something we're working on here in Idaho, and we'll be using Montana's example and others. And so we've done that. We've done it also for gunshot project materials as well, borrowing from other states. I think everybody's pretty good at doing that, and look forward to doing that even more as we bring zero suicide to Idaho. We're in the process of applying for 2 federal grants to bring zero suicide, and going to borrow from the states that have gone before us to help us work with our health system partners. And I want to say, just because there's a lot of Idaho people here, that we do have 20 health systems in Idaho on board for both of those federal grants, which is huge.
Wow, that's encouraging.
Statewide.
Okay, yeah, let's give a hand for that. All right, so we're going to go to the questions and answers from our audience next. So if you guys have those ready for me, then I'll get that started. But I do want to give you guys, this sounds so professional. I want to give you guys a chance. I'd like to give you experts a chance to share one thing that you really would like to say to state partners. What would that be? What's something that you would want to share with state partners? I see the wheels turning.
State partners being all of our hardworking advocates and
I believe
grassroots
so. Yes,
Oh.
and just in that collaborative effort. I mean, I've heard how you're kind of doing that, but if there's something that you would want to share that might be a catalyst for, for more collaboration, more partnership, am I kind of on the right track with that?
Yeah.
Mm-hmm.
So I think that we just found that the only way we accomplished anything of a grand, comprehensive style is when every single person was following the same message. So that'd be my message there. And my message to all the partners would simply be thank you.
Well, that's huge. Misty?
I would just like to thank Stuart and Shannon. This is the first of its kind. I mean, we know each other by name, maybe have run into each other every once in a while, and definitely are willing to share everything. And these are definitely my teachers. But I've never been in a room with most of you, maybe Anne. So keep this up. Keep these opportunities. I think Nevada's planning a conference in October. Never thought to make it bigger. So you open the door.
Anything else?
I know in Washington, I rely on a lot of our community partners. So initially, when I took this position, I thought I had that mindset of I have to respond to everything that comes my way. I need to spend the time to do that. And of course, that's not realistic. So I have to rely on my partners who understand their communities, have that expertise, and I can count on. And that's what I really appreciate about this conference as well, that we can learn so much from each other. Exactly. I haven't had the opportunity to connect with a lot of people from our region. And so this is just amazing to swap stories and just provide that technical assistance when needed.
Oh, I bet. I can only imagine how valuable this is. So that's great. All right, so I only have one question. Now, come on, y'all. You can do better than that. So if you have a question, let's oh, there we go. All right. Thank you so much. Let's get this one in first. Some states, such as Florida, have passed legislation to prevent mental health patients from being boarded in emergency departments while awaiting admission to a proper facility. Have any of you seen or heard of any progress in the Northwest to work towards this type of legislation? Yes, Steve.
So I found out that that was a serious issue in Utah, and sometimes the best way to get people's attention is to open up a bill file. So I opened up a bill file basically saying that if you can't place them within 24 hours, then they can send them to any facility, whether they're a contract provider or not, and they'll be reimbursed at these set rates. And when a top political official kind of in charge of this heard about that, they said, don't make that bill file public. We will fix this problem. And I said, well, it'll become public at 5 p.m. on this date, so if you have a solution by then great. If not, the bill file will become public, it'll hit the news, and you probably don't want to deal with that. So a number of emergency meetings, and they quickly tried to work things out with a number of providers to try to address that issue. It's still not perfect, but legislatively, you can force things like that if it's an issue, and bringing it into the spotlight was what started to get the wheels moving to address it.
And sometimes that is what you have to do. I mean, especially with a problem like that is so imminent. Right, that was a great question. All right, anybody else have anything in any other state that you've heard of? Okay. All right, here's the next one. I haven't read through this one yet. It says, I think we should say died by suicide, not committed suicide. Suicide is not a sin. Also say completed suicide, not successful suicide. No suicide is a success. I hope I haven't said that today. Stuart's been very kind to educate me and the media about it, and I've tried very hard to make sure all the reporters and producers and everyone know that, because I think that's important too. Do you all agree that that's very important? And so I apologize if somehow I didn't say that, but it's a big education thing. It's funny the habits that we have. I can't tell you how many scripts I've changed, even though I've sent out emails and I've talked to everybody about it. Those are very embedded language terms that we use, and so thank you for that comment. And I would just encourage you, if your local media is not aware, I loved how we were included in an invitation to come to some training, and I think we had 4 or 5 of our people there for that training. It's been a couple years ago now, but that helped tremendously, so I wasn't the only one out there saying it, and they could really hear the reasons why. So invite your media folks to trainings that you have, and I would ask you to maybe think about this. We're human, and we make mistakes, and sometimes we don't even know we're making them. I certainly didn't. And Stuart was very kind and compassionate in how he talked to me about it, and it enlightened me, and it's made me very well aware. Another thing you could talk to your media people about is every time they do a story on suicide, they put the suicide prevention phone number up, so that that's just a standard procedure. Occasionally we don't, but I say about 95% of the time we do on those stories now, and I think that's another way that we can help. So thank you for being kind about it, not calling me up and say, "You idiot, you keep saying that." Okay, another question? Anybody? Come on. Have we got another one? Because you'll have to listen to my questions if you don't have one. One's coming up. All right, it's on its way. Here we go. How fast can you run that 100 yards? Yeah, I think you're doing really well.
Cheaper than a gym membership.
Oh, I like this question. What trainings for lay people are working best? Also, youth trainings. That's a great question. Thank you for that. What's working?
In Nevada, we really believe in the Living Works model. Safe Talk, Assist, hopefully Suicide to Hope. We've trained over 15,000 people in Nevada. And what works for us is that mentoring. So we're going to currently train about 40 nurses and in-home visitors coming up next week and the week after. They were trying to beat the mandate, but the mandate still happens. So these nurses are going to be in pairs across our counties in the rural communities. But how we've built this train the trainer system is the office always mentors. We want to build that fidelity of the model because Assist and Safe Talk are complex. And we know those that don't do this for a living, that's a big thing to chew and bite off and chew. And so we are always going out there to support them with their first trainings, connect them in every way they can. And that seems to keep us growing so that we can reach more and more people. And we've done this with the National Guard. We're doing this with our corrections. We just did our first veteran inmate Safe Talk training with 50 veteran inmates. And now their deputy warden is going to go through Safe Talk next week and be a trainer for her staff in the jail or in the prison. So we are working with those cultural challenges, civilian, guard member. We train in teams so that way we can bridge the community, what they have, their cultural needs, but also what the community can do to help them.
Yeah, I agree with you. I'm a big fan of the Assist model as well. It's not for everybody because it's a long training. There are a lot of good quality gatekeeper trainings out there for adults. But I think when it comes to young people, we need to take a different look at this. We know, and past Garrett Lee Smith funding opportunities have shown that gatekeeper training is not what we need to do with youth. So when we're talking about young people, if we want young people to stop being at risk, we need to stop telling them how at risk they are. And we need to go upstream and talk to them about resilience and strength, and how they can find hope and help and refer their friends. And there are programs that do that as well, like Sources of Strength and the Good Behavior Game, which are well evidence-based programs.
All right, great. Did you want to add to that, Steve?
Yeah, one of our very successful programs for youth is our Hope for Utah. It was discussed in one of the breakouts, where Hope Squads are trained in peer-to-peer mentoring, understand things, the signs and symptoms to look for, and then referral to treatment. But their curriculum also goes into the resiliency skills and how to, be resilient themselves. So a volunteer program, and we find that youth are much more likely to speak to their peers than they are to adults, and it's opened so many doors for children to get into treatment, and we've actually seen our youth rate go down in the recent past, which we'd like to think is in part due to that.
All right. Boy, we've got some good questions here. So if you want to add something to this, go ahead real quick. Okay.
Thank you. So we have loved the assist model, but for our workplace, that really wasn't an option. So we had to go with a much briefer model, and QPR was easily available in Wyoming, so we used QPR as the model. But we really wanted to make sure that it was effective, so we surveyed all of our participants 90 days after they went through the training, so kind of a rolling survey. And what we found is 48% of those who went through the training and responded to the survey, 48% said, I used that training in the last 90 days 2.3 times.
Great. All right. Let's get to some of these other questions. How are the increased rates of suicide related to the opioid epidemic and/or veteran suicide? What do we know? We know anything about that connection? I'm seeing not much. It's tough, isn't it? It's so hard. I know as a reporter, it's hard to get data. It's very hard. It's hard to know. Yeah.
On the team that I work with, we also have a program manager who works with our opioid overdose grant. So our data, we have our same epidemiologist working on both sets of data. So it is very interesting. And I think one of the huge challenges is just how they determine intent. And I'm not sure what the right answers are. I don't know how we work, because we all understand in this room that, of course, there's a connection, that substance use is a coping mechanism, that it's tied in, but how you can say, or what it takes to convince others that it can be connected with suicide is a challenge. So we're hoping with NVDRS, the National Violent Death Reporting System, Washington will have our first set of data this year. Maybe that will give us some insight. Perhaps some of the folks who have been doing it for longer, maybe you already see some patterns. But yeah, it's a definite challenge.
Okay. Okay, the Youth Risk Behavior Survey, which comes out, it's widely distributed. Yeah, people see that. Okay. All right, real quickly.
A bill that I ran in Utah allows naloxone, also known as Narcan, to be sold over the counter from a pharmacist without a prescription. We have a standing order from our state medical director, and we've had several bills on getting naloxone widespread through our community. And over the past 22 months, we've had 1,100 reversals where somebody overdosed either intentionally or unintentionally, and with a quick shot of naloxone, it's brought them back and put liability laws in place so anybody can administer it to somebody else that they believe is in overdose.
Right. All right, good. Well, okay, I have so many good questions here, and how much time? We have like 8 minutes maybe? Okay, so here we go. So I'm just going to ask one of you to jump in and answer these questions real quickly, but I've got a couple about 13 Reasons Why. So one of those is, have you observed any impact on suicide as a result of the 13 Reasons Why Netflix series? The other one is, any ideas about how to address 13 Reasons Why in schools? So somebody jump in on those.
So we don't have any data in Oregon that people watched it and then killed themselves as a result of it. But we do know that the emergency departments are packed with suicide attempts. We know that clinicians are getting a lot of calls. So we know anecdotally there's been a huge impact in the state. Some of our school districts have created packets for staff and students and to send home. Wonderful, wonderful packets. And at the Oregon Health Authority, we issued educational information through the media. And the approach was, we prefer your kids not watch it, but if they do watch it with you and have a conversation around it.
And I'll just mention there's a 13 reasons why tip sheet back on the span table back there that can help anyone know how to talk to kids about it.
Okay, anybody else have a quick comment about that?
Through our statewide network, we jumped on that really pretty quickly when it came out, and advertised the 13 reasons why not, and to mobilize students to develop their own anti-13 reasons campaigns within their schools.
Okay. Next question. We can identify risk factors for different groups. One of these groups is the LGBTQ community, who has a risk 4 times higher than the general population. What are your states doing to attempt to manage the increased risk in this population? Is there anything specific that anybody has to say about that?
There's a recent study out that indicated that youth who are exploring their sexual identity or gender preference are feeling less stress, and it's likelihood there's less suicidal risk because of gay marriage, because there's a societal recognition that it's okay. And so I think that is one of the biggest things our society has done, and I believe that it is going to impact the suicide rate.
Anybody else have a thought?
So there have been laws on the books that don't allow LGBT issues to be discussed per se in school. We created something called the Safe UT app that over 10,000 students have loaded on their phone, that they can send in anonymous tips about school safety issues and also chat real-time texting with a crisis counselor 24/7, 365, which has been hugely successful. And one of the topics that is a drop-down menu they can select to chat about are LGBT issues. And those, because it's done through our main psychiatric hospital with LCSWs, it's outside the realm of public education. So a teacher can say, if they're approached about that issue, use this app, and then they have resources that those students can reach out to without any legal issues.
Okay, great. All right, anybody else? Misty?
I just wanted to add, we have a pretty strict anti-bullying law that I think has just changed, but one incident was enough to suffice, and they have to implement something within 24 hours or they're penalized, the administrators and school team. So along those lines, we are implementing Safe to Tell, which is based on Colorado's web, text, phone framework, and I'm thinking that will impact. But what they have found is suicide is the highest reported incident. Bullying is second to that.
Wow. All right. Let's try to get this one. Will the panel comment on the issue of media not saying a suicide is a suicide? Is not acknowledging a suicide just furthering the notion that if we don't talk about it, it isn't an issue?
How you talk about it is important.
Yes. Yeah. It's a challenge. I can just say from the media's perspective, we don't report something that we can't say, it was a suicide if some official doesn't tell us. And we've been talking about that issue, that a lot of times that it might be suicide, but that's not the way it's reported. And then we're still trying to grapple with that issue as the media as well. This question that you raised earlier, that maybe isn't a question, that not talking about it is not the right answer.
We were just contacted by a national news magazine wanting to do a story about some things we're doing in Utah, and a good friend at Harvard University gave us some great advice that they have research that shows that if you talk about success stories and people who have struggled with mental illness and suicide ideation, but they are now in a better spot, that is very protective. But if you're talking about how people died, the methods, it will increase and can create contagion. And so, again, talking about the suicide numbers are very helpful, and where to go for resources is the key.
All right, that's good. Kim, did you want to add?
I just wanted to mention that there are very good do's and don'ts in the national media guidelines for them if people are uncertain about what's okay and what's not okay. But I want to highlight what you just said, because what people need, that I don't think we know enough about, because it's such a problem, and we're constantly talking about suicide and completed suicides, that we need to understand that when it comes to suicidality, recovery from suicidality is the norm. Vastly, most people who ever think about it, plan it, or even make an attempt, recover from suicidality. And we don't talk about that enough.
I really appreciated being able to have Kevin Hines on the other day, because that message, and has he spoken already at this conference? That's tomorrow, this afternoon. Oh my goodness, that'll be powerful. But yes, having those kinds of stories from a media perspective is very helpful to do it in a positive way. So, okay, last question. Oregon has assisted suicide for people who have cancer or other terminal diseases. Do you think this is a good model for the older generations, for all states, to help reduce that number of suicides for that population, which is mostly elderly?
I guess Oregon is on the spot. I am not an expert in death with dignity, which is the Oregon term. It is not considered suicide. In Oregon, on the death certificates, it's considered a natural death. So I can't be very helpful as far as that within the arena of suicide. But it is used very little. And what we're finding is that even among people who do get the prescribed medication, they're not using it. So it's really not an epidemic of people choosing to end their own lives. And they have to go through significant assessments by physicians in order to even get the medication.
Anyone else have a thought on that, Misty?
Nevada had a bill in the session that passed one house and did not make it out of committee right at the end. It was difficult. I got a call from someone, what's your position on the death or suicide bill? And I will only speak from my personal opinion. I see them as vastly different. Suicide prevention and this are different, and our committee to review suicide fatalities had a huge discussion. What we were finding with our older adults, the missed opportunities were with their primary care, their pharmacy. We didn't see any other opportunities for prevention, but we thought if they had this option for death with dignity, the violent, traumatic suicide deaths might be reduced. That's only speculation, so we would be interested to see if Oregon had data on that. We hope the bill might give opportunity to reduce suicide in the elder community.
Boy, wow, could you believe we left that for the very end? Because we could talk about that all afternoon, and a lot of thought-provoking things to be working through. Oh, thank you. You guys came through. Give yourselves a hand. Good questions. Thank you so much. I appreciate that. I appreciate so much this panel and being able to be with you today, and thank you for the work you're all doing. Everybody who's here, I just can't even imagine the impact that you'll have now and that you're already having. So thank you from our community and our state. We appreciate you, and we really appreciate that you would participate in this panel. Thank you all.
That was the trailer for the film Suicide, The Ripple Effect, a documentary I've been making for the last 2 years with a great friend in mental health, Greg DeCherry, and a good friend in editing named Ryan Moser. And we're making this film because we truly believe in the power of stories of hope, helping people find recovery and healing. And if you even talk to the Deputy Director of SAMHSA, Kana she can tell you that the science is pointing toward stories of hope with the aspect of recovery, and you probably heard this earlier today, actually having a transformative effect on people and changing their lives so much that they choose to live. And you can see in the brain when someone is listening to a story like mine or the people in the film, you can see the change that is occurring and the instances of empathy that are occurring and the instances of people putting themselves in the storyteller's shoes, and those who are suffering terribly, who are in that great amount of brain pain, changing their lives after hearing a story like this. And we see it countless times when people have approached us as the people in the film. We have a collective of about 36 individuals. They won't all be featured in the film, but 36 individuals are part of our group, this Conquer Collective, Courage to talk about mental health, normalize the conversation, question. Ask the question, are you suicidal, and do you have a plan and recovery? Because we know it is possible with good, proper treatment and care. Listen, I think before I go any further, we have to do one thing together. We have to take a moment of silence for all of those that we have lost to suicide, and to all of those that we know, that we love, and that we care about with any kind of diagnosable mental illness or substance abuse battle. So if we could do that, I'd appreciate it. A moment of silence. Are you okay? Is something wrong? Can I help you? Some of you know why I say those as my first words of this speech. Those were the only words I wanted to hear as I stood atop the Golden Gate Bridge walkway, crying like a child, waterfalls flowing from my eyes, mucus dripping from my nose, begging myself to turn around and to call literally anybody to ask for help. And you'd think it would be so simple. The morning before I got to that bridge, my father looked at me. I startled him awake at 6 in the morning. I don't even remember walking in there. I remember startling my dad awake. He wears one of those CPAP machines you guys know about, some of you, all right? Makes you not snore. He was still snoring, I'm just saying, it's defective. And he's wearing the machine, right? He's wearing the CPAP machine, and he sounds like this. Like Darth Vader. Except he was my father. So there's that. And if you happen to be a Star Trek fan, there is the door. No, I'm kidding. But my father startles awake, and the first thing he says to me, Kevin, what's wrong? Parental instinct, right? I had been acting erratic all week. I had been living with bipolar disorder, the diagnosis, for 2.5 years. I didn't believe it. I didn't want it. Oh, was I taking the meds? Sure. One day and not the next. 7 days and not for 7 days. Or how about when I took it while binge drinking until blackout on the weekends? Alone in my room. I wasn't trying to get high. I was trying to numb the voices in my head. And my father that morning, he did everything he could that he knew about. Kevin, why don't you come to the movies with me today? He said. No, Dad, I can't. Busy day at City College. Kev, we'll go to the beach. Sorry, Dad. Sorry, no. Really busy day at City College. Kev, I think you should come to my office. I just have this weird feeling that you should be with me today. Spot on, right? Something was really getting at him, and he knew something was wrong, but he couldn't quite pin it. And as my father is fond of saying, he has many sayings. One of them is, Kevin, what the hell are you doing? It was one of his mantras, all right? That's just one thing he used to say. But another thing he used to do, he wanted me to be with him so bad that day. And it would seem so simple for me to answer his question with a response like, Dad, something's wrong. This is what I'm feeling, but I couldn't. Because every time I wanted to say, Dad, help me, the voice in my head, the auditory hallucination, a man's voice in my head that I couldn't recognize as anybody I knew or loved, screaming in my head, be quiet, Kevin. You have to die, Kevin. You don't have a choice, Kevin. So I lied. Fine, Dad, I'm feeling better than last night. I slept on it. I hadn't slept 14 days and 2 hours. But 2 hours. Insomnia, you all know, causes psychosis all by itself. Add that to bipolar disorder type 1 with psychotic features, chaos. I felt like bugs were crawling in my skin the entire night. My book bag, my shoulder bag, was packed by the door. All of my City College school books were on the desk. And sadly, the night before, I had gone online looking up ways to die. And some of you know what I found. Those awful sights. To have no care for a human being in the world. That can be a catalyst, and are a catalyst to so many people around the world losing their lives. I never wanted to die by suicide. I only came to a place in such immeasurable mental instability where I believed I had no other choice. I thought my family hated me. I thought my friends disowned me. I thought that I was their greatest burden. You've heard that before. This perceived burdensomeness that suicidal people have that exists to usually only them. And nobody else around them, or a lot of other people around them, aren't thinking those things. Nobody in my family hated me. My friends didn't loathe me. Had I called them and asked them those questions, you know they would have told me otherwise. And yet I stood in my room looking at the only man who loves me the most in the world, my father, Patrick Kevin Hines, and lied. Not because I wanted to, because the voices told me to, and they were winning the day. Finally, my dad, he looked at me, he says, Kev, I'll tell you what, you seem like you've calmed down, the calm before the storm. As a matter of fact, you started smiling. You haven't been smiling, you seem happy, he said. Yeah, I was happy, elated. The pain was finally going to end. The throbbing in my head was going to stop. I was going to be free. What is the one thing you want pain to do when it's copious amounts of physical pain? What do you want it to do? Stop, go away, leave you alone. And you do everything in physical treatment to stop that pain. In the hospital, they re-break an arm and they set it. In the hospital, they give you medication and you feel better. But for the brain, it just ain't that simple. I wanted the pain to stop. The common denominator of those we love, we know, and we care about who die by suicide, not commit. They die by suicide from their pain, from depression. And maybe they don't all have mental illness, but they are all suffering. My father looked at me and said, Kev, you seem like you feel better. Why don't I take you to City College and you take the bus home today? Sure, Dad. Sounds like a plan. I'll see you home at 6 tonight. All I had to do was tell him. I got in his car, I gripped my shoulder bag to my chest. You know why? Because the note I had put in my notebook was in there. A note that only 20% of people who actually die by suicide actually write. Dear Mom, I love you, but you're not always right. Dear Dad, I love you too, but stop bringing the office home. This isn't work. My dad was a businessman, a banker. He had been poor as a kid, piss poor. His parents, substance use disorder, what we all call alcoholism. They would die of that disease at a very young age. My father had a job at 11. 11. That's called a lack of a childhood. He was a hardened man at 11. And he grew up and all he ever wanted to do, Pat Hines, was build a family that he could love like he really didn't have. He married his childhood sweetheart. They were best buddies since 2nd grade. 25 years of marriage. And then, because apparently opposites can only attract for circa 25 years, they got divorced. And I was living with my dad because of that divorce, and I was then in that car on that day, September 25th of the year 2000. I was in that car gripping that shoulder bag to my chest. I didn't want my dad to find me out. I didn't want him to stop me because of the pain. We got to the kitty corner off the side of the City College campus that day, and my father turned to me and he said one of his other mantras, this one I like, Not, Kev, what the hell are you doing? This one I like. He turned to me and he said, Kevin, I love you. Be careful. Like a good old dad would. And I kissed my pop on the cheek as I had done since I was about yay high. And I told him I loved him because I thought it was the last time. And I stepped out of that car with my right foot and I stood. And a tear rolled down my cheek, off my chin, and onto my right lug's boot, onto the middle shoelace. I'll never forget that moment. It's imprinted in my brain. And as I watched my father drive away, I said to myself, that's the very last time I will ever see anybody I love, and the very last time anybody I love will ever see me. And I was content to die. And I wiped the water from my face, and I walked onto campus. I walked into the counselor's department. I found the most readily available counselor. I asked her to drop me 9.5 of my 12.5 units, leaving only my English class. I sat with her. I told her what I wanted her to do. She didn't ask me one question. Not one why, who, what, when, or how. Are you dropping these courses? Click, click, click. Classes were gone, and immediately so was relinquished my medical coverage from the school's wellness program. Now, I thought that wouldn't have mattered even if she did tell me that that was going to take away my coverage. Because I thought I'd be gone, because I thought I better go to City College to drop my courses so Mom and Dad don't have to do it after I die. Because, God, they'd be so mad at me, wouldn't they? Mad at me if I dropped my courses. Not mad at me because their eldest son just died by his hands. Irrational thoughts lead to suicidal crisis. Not rational thoughts are not true realities. I went into my English class, and people have asked me over time, why English? Some of you know, it's very simple. It wasn't because I was trying to become a literary master, certainly not. Some of you have read my book, it has errors in it, okay? All right, like 36 of them, okay? You're free to find them. Just tell me where they are. And no, that wasn't why. It was for one silly reason. The reason I kept English was because the teacher was gorgeous. I just wanted to see her one last time. It was the only rational thing I did all day. And I left that class early, looking back at that note in my notebook and making sure it was all right. Even though any one of those notes is all wrong. I got on a Muni train. I sat in a cornered area looking out a reflective glass, and I saw that man. That man I no longer recognized and hadn't recognized in a long time. That man that when I was at home, when my father was at work trying to provide, and he thought I was going to City College to get my education on days and months before that, I'm at home staring at that man in the mirror every day, loathing every fiber of his being. And he's telling me what I have to do, and that I have no choice, and that it is inevitable, Kevin. I remember looking at him going, but why? Out loud, what did I ever do to you? Why do you hate me so much? I don't want to die. And on the day before my attempt, I punched that man as if it was a separate person, and all I got was a bloody fist. Because I couldn't recognize that it was always just me. I got from that Muni train onto a bus. And it was on that Muni train that I got a transfer, a paper transfer. It's all I had money for. I only had enough money to get on the bus, to get the transfer. I had no cell phone. I had left mine at home. The worst part about that, my sister, who you saw in the film trailer, the blonde girl, the short blonde girl, Libby, she called me every day before school, every day, without fail, at the same time, to tell me she loved me. And this would be the only day in that school semester that she thought, oh, he's fine. I don't need to call. And little known to myself, she would go on to blame herself for 15 years. I got on that bus. I sat in the very back row in the middle seat, looking on at what eventually was about 100 people, all staring right at me. And I began to cry, softly, moderately, and then waterfalls flew from my eyes and mucus dripped from my nose. I cried and cried on that bus, begging myself to tell anyone while the voices told me I had to die. My brain was trying to kill me as I desperately tried to cling to life. And the bus got to the Golden Gate Bridge parking lot because that's where its last stop was. And 100 people deboarded with their fanny packs that were like neon green and orange from 1985 in the year 2000. Who had a fanny pack? Come on. Come on, raise those hands high like you're proud of yourself. All right, it's like a bat belt. It's got everything in there. Everyone should have one. As a matter of fact, when I walked in here, someone told me that all of your friends want one. Only neon pink, though. And they got off that bus with cameras that your kids don't understand because they're not phones. And they got off that bus with foreign accents from all over the world. And they were there to create beautiful memories for all of those back home. Because that's what you did at the ninth wonder of the world. That's what you did at what some call the most beautiful man-made structure ever created. Clearly, that guy was a San Franciscan. But that's what people did every day. 20 million people cross that bridge a year, even more now today. But how many of you know that one person dies there every 7 days? Now, when I was on that bridge, ready to die, leaning over that 4-foot nothing rail, that ease of access to lethal means, contemplating my end, hearing the voices in my head, the officers that rode by on their bikes, they hadn't been trained in suicide prevention yet that year. They are today. They save about 100 to 120 lives a year, every year. They drove right by me, twice. Bikers, joggers, tourists, runners, police officers searching for suicidal people, right by me. And that's when I turned to my left, and a woman was approaching me. She had blonde, curly hair, and those sunglasses you ladies love to wear that don't fit your face. You know, the big ones? Who has them in the purse right now? They're on her head. I see it. All right. You look like a bug. I'm just saying. Just think about it. No offense. No offense. All right. No offense. All right. And she approached with this beautiful smile on her face. And I thought, she's going to ask me if I'm okay. I don't have to do this. I'm 19, and I don't have to die today. Because I can tell her everything. Because you see, on that bus, I made a pact with myself. You know this pact. If one person says or does this, I will. And if one person says or does this, I won't die today. You ever read the book, Why People Die by Suicide by Dr. Thomas Joyner? You remember that story? That man in his 40s went to the bridge? In his note, he said, if one person smiles at me, I won't jump. May he rest in peace. That man died for the lack of a smile, the turn of a cheek. So we're going to honor that man right now. Turn to the person closest to you and give them the biggest, whitest teeth smile you possibly can. Because 1 in 4 of us have a diagnosable mental illness, and 1 in 4 of us is hurting. Smile. I want to see those teeth. I want to see the choppers. If they're not white teeth, it's okay. Smile anyway. Come on. Yeah. All right. Yes. Now, how hard was that? Sometimes, you guys, it's not about suicide prevention. Sometimes it's not about getting all the questions or the answers right. Sometimes it's just about sitting down next to the person in pain, putting your arm around them and saying, I got your back. And I'm going to listen to your pain. And I'm going to hear you. And I'm not going to let you go today until I know you're safe. I did that recently. I was, when I was still living in San Francisco, my wife and I moved from San Francisco to Atlanta recently, and I was living in San Francisco. I lived there my whole life, 34 years, and my wife and I were walking down Market Street, and this, maybe 16, 17-year-old girl is standing at a corner. I think it was Civic Center or Market, and she's standing at the corner, and green light, red light, green light, red light, and she's going like this at every green light for this wave of traffic, like this. And my wife knew. She said, "You're going to ask her if I said, "Yeah, I'm going to ask her if she's okay." I walked up to her. I walked in front of her so she couldn't. I said, "Are you okay?" And it shocked her. She goes, "Why do you care?" I just said, "Because I do, and you don't look very well. You look like you're hurting a lot. What are you doing?" And she put her head down. Tears. I said, "How about we go sit over there? See the curb? We just go sit there. Would you sit with me?" And she said, "I don't know you." I said, "Yeah, you do. I'm someone who cares." And we sat down. And my wife stood at the corner, so in case she ran, my wife would block her and tackle her. My wife's a boss, right? Yeah, she'd take care of it. And I sat with this girl for the next 20 minutes. And of course I asked her, are you in danger of suicide? Are you thinking of suicide? And tears in her eyes got even worse, and her eyes turned red. And she looked down at the ground in a great deal of shame, and she said, "How did you know?" I said, "It's written all over your face. And I know because I've been there, and I'm there all the time." And she said, "How do you do it? How do you stay?" And I said, "Because I know I have purpose. And no matter the fact that some days I see no hope, I always know it's there. And I'm committed to life, and I will continue to move forward." We just sat and chatted, and I listened to all her stories. And my wife was patient. My wife's not a patient person, but she was patient. In all these moments like this, we have them all the time. She's patient because she cares. And eventually, I said to the young lady, "Are you safe?" And she said, "No." And I called the police. The same police that before my 5th psychiatric hospital stay, someone called on me. Just a few years earlier, before my 5th psychiatric hospital stay of 7, between 2000 and 2011, after that jump. I'll never forget that moment. First time put in the handcuffs. I was at my favorite cafe, and that morning, my father had given me a notebook, and he said, "Kevin, what you got to do, Kevin, is you got to just write down all your thoughts. When you're manic, that's what you have to do. You got to write down all your thoughts and get them out of your head and onto paper." That's what he tells me one day, and I'm really having a hard time. Once again, I'm not telling him what I'm really feeling. And I go to my cafe, been going there for 10 years, and the cafe, proprietarian, we're just chopping it up, and I sit at my table, and I was like, "Oh, I gotta write these thoughts down," and I start writing chronic, suicidal, manic thoughts. I remember looking back at this. It said stuff like, "My wife is going to kill me. My father and my wife are planning to kill me." It went on for days. And I remember at the end of that writing, I looked at what I had written. And because I had been self-aware for the last 2 years from that 3rd psychiatric hospital stay, I was like, "Oh man, this is what they're talking about. This is a symptom. I now know it. I need to call someone." Because I saw what I was writing, and it was terrifying. And I called my 2 best buddies who I knew were in the vicinity. And they were part of my personal protector plan. I have a mental health emergency plan that everyone should have, right? We all have mental health. We don't all have mental illnesses, but we better have a plan, because none of us are immune to that stuff. Not even the doctors and clinicians and zero suiciders and mental health first aiders. We're not immune. And at any given moment of pain, you can go there. And so I called my best buddies, Too Tall John Davies and Zen Master Joe Hurlesy. And they're just massive human beings that played football with me. And I knew that if I was going to run for that bus to go back to the Golden Gate Bridge, which was my plan, they would stop me easily. And they came within a flash. John got there first. He sat down. He said, Kevin, what's going on? I slid over the notebook. He looks at the notebook. He goes, yeah, buddy, you're going to the clinic. Okay. The clinic was across the street. I was waiting for my appointment. And Joe Hurlesy gets there, and John slides him the notebook, and he goes, oh, God. And he was the security guard at a psych ward, so he understood. And they stood at the corner, but they didn't take away my dignity. They said, Kevin, you know what you have to do. You have to go in there, Kevin, you have to tell them you're suicidal. I said, I don't want to do that, man. I don't want to go back there. Those places are terrifying. I mean, I learn a lot each time, but they're terrifying, guys. They said, Kevin, terrifying or dead? I said, Kevin, we're going to stand on this corner, and we're going to watch you cross the street. And if you do anything but walk in that opposite street's door at that clinic, we are going to take you down. Okay, all right. I remember I walked across the street as the light turned green, and I stopped, kind of like I could run for the bus. And I looked back, and they were there like this. And I was like, yeah, I don't want to get hurt today. But did you hear that? I don't want to get hurt today. Physically hurt, but I thought I had to die. It's ridiculous. Irrational thoughts. And I walked into that clinic, and I walked to the nurse's station. It's like there's a glass window covered by a wall and a door that's got a number code so the crazies can't get inside. That's what they think. I know it. And I was one of them. And I go to the window, and I'm just bawling, just crying my eyes out. And I said, Gloria Fresh Federico, she was my therapist. She was the best therapist in the world. I hated when she changed jobs. It's the worst. Had to start with all over again. You guys know. And I asked for Gloria, and she was available right away. She looked in the window. She said, Kevin, come on. She knew my look, And she comes around. She opens the door, and she takes me back, and we sit down. I sit down with Dr. Lee. He was one of the best psychiatrists I ever had. Both of them have saved my life on countless occasions. I owe them a lot. And I sit down in the couch. I'm just crying my eyes out. I can't get my words out. I'm stuttering, stammering. Gloria puts her hand on my shoulder. Says, Kevin, what are you thinking? I looked up at her. I said, you know what I'm thinking. She said, I need you to say it. And even after all that time, after a 5th psych ward stay and so many suicidal crises, I was ashamed to say it. Because that is what our culture has taught us. To lie about our pain. Because people won't understand in our minds, and we'll be that burden. Doesn't matter how old you are. Doesn't matter how strong you are. Doesn't matter how fit. Doesn't matter if you're a male or female. So many of us around the world feel such shame in those thoughts that we silence our pain. If you are going to do anything past today, just maybe one thing, and learn one thing from this speech, I ask you that it be this: never again, when you walk out those doors and you go about your regular life and you do your work in the field and you get us to 0, never, ever silence your pain. It is real. It is valid. It is yours. And it matters. Because you matter. And the only reason we lose 1 million people globally to suicide is because they are silencing their pain from shame. And I was sitting there in that seat with Gloria and Dr. Lee, who I'd been seeing for years, and I couldn't say it. But when I did, a police officer walked in, and he asked me quite nicely, if I could stand, and if I had anything sharp in my pockets that would harm him. I said no. And he went through the search, and he agreed. And he said, will you walk with me? I'm going to put my hand on your hands behind your back. Are you going to be compliant? I said, yes, officer, I will be compliant. And he said, now people say that and then they aren't, so are you going to be compliant? And I said, yes, sir. I like police officers. And he walked me outside, and another officer met him and held my shoulder, my elbow. And they got me up to the car, the black and white. And in front of my favorite cafe with everybody I knew by a first name, some last names, they leaned me over the hood, and they put the cuffs on my hands. And it wasn't like in the movies where they get your head and they shove you in. That happens maybe sometimes, but it didn't happen to me. They looked at me and they go, get in. And I looked at them like, what? How? I don't have any hands. They go, figure it out. And I'm it's a small window, so you're just like, it's like an Olympic vault or something. How do I do this? And I put my hands in and I leaned in and I jumped in. They could have told me that. And I'm in the car and I scooch up and I sit down and they are sitting in the front seat and we start to move and I'm crying my eyes out, but I'm quiet because of all the paranoid thoughts. And the rookie turns around. He's a guy in the passenger seat. He turns around and he won't stop looking at me. I think I'm like in more trouble than I've been. Did I rob a bank or something? What's going on? Is there something else happening and you're not telling me? And he goes, hey, what's your name? And I told him, he said, do you give the rookie San Francisco police officer talks on mental health every year? I said, yes. And the senior officer turns around, pulls the car over and goes, so how we doing? Oh, man. And I said, this is my first experience with this, but I think you're doing well. And we laughed. But do you see what that was? Connection. I connected with the men that most would think were my adversaries because of a very important tool that we all have in this room, but that we need the world to have: empathy. The only tool, the only resource we have that can salvage this world from all its woes. Empathy. Looking at other people, putting yourself in their shoes, and going, that could be me. We got to the psychiatric emergency services. And they parked and they said, okay, Mr. Hines, we're going to bring you inside. We're going to take you to intake. We'll see you through intake. We will take off the cuffs, but only if you're compliant. I said, yeah, I got that. And I'm shaking, and they get me up there. They get me inside. They take off the handcuffs. They sit me down. But now I'm shivering. I'm shivering, and I'm sweating, and I'm having a panic attack. I had started to have quite a few of them during my 5th psych ward stay. Heart palpitations out of control. You feel like you're going to have a heart attack, but that's not how it works. And you don't know that. You just feel like it. And I'm sweating like a madman, and these officers started getting calls on their radios. Calls to things that were more important than me. Calls to things that might be dangerous, and they had to go help their buddies, And I didn't want them to leave. I felt protected. And they sensed that. And the senior officer to my left, put his right hand on my left shoulder. And the junior officer stood to my right and put his left hand on my right shoulder. And they looked at me and they said, son, we're not going anywhere. You help us and we're going to help you. And they stayed with me until the panic attack subsided. And they stayed with me through the intake and through the medication. And they stayed with me until a man to our right, an older gentleman, coded having a real heart attack and dropped to the floor, and they had to revive him with the chest clamps. And of course, the panic attack started up again. Because now I'm like, no, these are, it's the same thing, you know. And well, the officers let me calm down again. They stayed. And they only left when they turned to me and said, "Are you going to be okay?" One of the kindest things any two people has ever done for me. You know, having been in 7 psych ward stays, all for suicidal crisis, the one thing that got me through the whole lot of it was faith. Hold on. I'm not talking about necessarily faith in God, which I have. I think people should have faith in the human spirit and in themselves and their ability to survive and thrive. That's what I have. I didn't always have it. But it was in my 3rd psychiatric days, 2 psych wards back, that everything changed. I had been in 3 involuntary psych ward stays between 2000, when I jumped off the bridge, and 2004. 3 psych ward stays in 4 years. All for suicidal crisis and acutely dangerously close to suicide. And my family and my friends, luckily, had intervened each time and gotten me to safety. In that 3rd psych ward stay, I remember I had a beard jutting 6 inches off my face, and I had like this, like a half-fro, not an afro, a half-fro. And it was like fiery red, you know, because that's what the color of my hair is when it's long. And anyway, and it's out there and it's wild, and it's like a mane. I look like a lion. And I'm in this psych ward, and I got a 2-month stint because Mom and Dad won't take me back. Separately, they were like, "No, Kevin, we can't do this anymore. You're not getting any better. We need you to do something to get better." And they said, "You're going to have to go into a halfway home." All right? I felt abandoned. I've had abandonment issues my entire life. I'm adopted. My biological mom and dad, Marcia Silvera and Martino Perales, they had substance use disorder, hardcore drugs and alcohol. They would leave me and my infant brother unattended to go score and sell and do those drugs. They would leave us lying with a bruised sternum from the top of our sternum to the bottom of our abdomen, distended bellies filled with liquid. We were fed what they could steal: Kool-Aid, Coca-Cola, and sour milk. And they left us unattended too many times because one seedy motel clerk on 6th Street in San Francisco, it's not a good place, heard our screams and cries, and he called the police. That's where my journey began. Foster care for the first 9 months of my life. When my brother died, we both got bronchitis. He died, my only full-blooded brother. And unlike my brother, I of course got lucky. You know where my path led me. Pat and Deborah Hines took me in and they made me their son. They made me their son, and they had 3 kids from 3 separate families into one family. Pat and Debbie Hines, Irish and German. My sister from a different family, white. My brother, black. Me, mixed. You can just think of this. I'm everything but Russian. Yeah, just go with that. Or as Donald Trump would call it, American. I win at everything. I'm the winner. I'm the boss. The champion of change. Sorry. It just comes out of me. I can't stop it. In any event, you know, you can imagine growing up as a mixed-race family in the 1970s and 80s, right? In 80s. So imagine walking down the street with your mom and your brother in the stroller who's black and you who look tan and your sister who's white, and people just kind of bewildered looking by, you know? And people would stare at us like we were a circus act. Women would cross the street to talk to my mom, and they would look at her and they would say, "Excuse me, how did all of that happen?" And that's when my mother would very quickly reply, "Oh, you know, different fathers." She was a boss too. It was great. And we didn't care because we were a family that was happy. We were a family that was in love. And that's a whole nother story. Let's get back to that 3rd psych ward stay. I had that long beard and that half row, and my Uncle George came to see me. Now, I thought he was coming to make me laugh, because that's what he always did. Uncle George would come to the psych wards, he would like plan it around the time all my friends were coming, and he would make them laugh to make me laugh. Now, Uncle George does not tell regular jokes. He is the most HR unfriendly person you'll ever meet. You do not want him to talk to anyone you think is important. It will get ruined. And so he would come in and he'd say things that were just totally inappropriate but hilarious. And he'd come in, but this time he wasn't laughing. And Uncle George, he would drive to my psych ward stays, every psych ward stay without fail, with sciatica in both knees and diabetes. That's love from 6 hours away in Arnold, California. That's love. And one day he made a special appointment with my case manager, one where nobody else was around, just me and him. And he comes in with a rolled magazine in his hand, and he sits down and he says, "Kevin, what are you doing?" He said, "Your family can help you until we are blue in the face. But until and when you take 100% responsibility for the fact that you have this disease, and you fight it tooth and nail every day, Kevin," he said, "ain't nothing gonna change. And you'll be in and out of these places for the rest of your life." And he dropped the magazine on the table. It was a Time magazine article in 2004 on bipolar disorder and depression and fighting it with routine and regimen, which oddly enough in 3 psych ward stays no one had told me. And he goes, "Kevin, read the article and get your shit together." And he got up and left. And I went back to my room seething, and I grabbed that magazine, and I was like, what does he know? He is not my favorite uncle anymore. He doesn't understand what I'm going through. He doesn't know what I'm dealing with. And I sat at a chair in my psych ward room, staring at the wall across from my bed with the bed that had the Time magazine article on it. I stared at that magazine for 2 hours. Very productive. I picked up the magazine, I read the article. And then I read the rest of the magazine because it's Time. And I read the article again. It talked all about building a very strict routine to balance your brain health. I can do these things like on a regular basis, and I might feel better. I want to feel better. I started putting them into practice every day. I went to my nurse's station. The evening staff was there, and I said, "Excuse me," and I talked to one nurse, I said, "Can you please wake me up like an hour before everyone else and give me my pills then so I can get used to that?" And she said, "Sure." I said, "I take night meds. Can you do the same thing but an hour early before everyone else goes to bed? And I'll go to bed early with them." And she said, "Sure." I said, "I'm having trouble sleeping." And she got a friend of hers, another nurse. She came over and said, "Kevin, you're having trouble sleeping. We noticed that." I said, "No, I'm an insomniac. I'm not, and she goes, "I have an idea." And she comes back the next day with a $2.99 CD player from Walgreens that she bought for me, and 3 CDs that were somehow, entitled like transforming your sleep patterns. And one was whale noises, ocean noises, and rainforest noises. And they were meant to change your brain waves, literally, as you laid to rest. And what the nurse told me, she said, "Kevin, now I know you can't sleep, but what you have to do is lay in bed and stare at the ceiling or count sheep, and you can't move. Don't get up to go to the bathroom, unless you really got to go, but don't get up to the bathroom. Just lay there and be, and listen to these songs and these patterns." And I was like, that's a bunch of nonsense. But then I started doing it. Night after night, I did it. On the 3rd night, something hadn't happened that happened on that 3rd night. I start to go like this. I'm like, oh, it's working, yeah. And the 5th night, my eyes closed for like minutes at a time. The 7th night, I actually slept 3 hours, and I continued this for the next 2 weeks. And by the 2nd week, I was sleeping, not for a long time, but enough. And I continued to grow in that sleep pattern. It was fantastic. And then I went to the nurse's station the next day, and I had been pretty overweight. You know, I'm 5'7", and I wasn't taking care of myself. I was near diabetic at the time. I was a big guy. And I go in there, and I go to the nurse's station. I say, hey, you know, do you guys have a gym? And they looked at me like I was, you know, and they looked at me, and they, yeah, right? And they looked at me, and they go, son, this is a psych ward. And it dawned on me, every psych ward should have a gym, right? Every psych ward should have a gym. Endorphins released in the body from exercise help people feel better and balance mood. And so I started to remember, I was a high school wrestling champion. We didn't use weights. All we did for 6 hours a day, each day, double days, was work out with our body weight against itself. I know how to do this. And I started working out in my room like a maniac, you know, as they say. And I really worked out. I worked out every time I wasn't in therapy, every time I wasn't in a meeting, every time I wasn't doing something important for my brain health, I was working out, which is important for your brain health. So I'm losing the weight. It's coming off me. I've got those 2 months to stay in there. I'm doing all these things, and magically I wonder why I'm feeling better. And now the hallucinations and the distortions and the paranoid delusions of all the other patients aren't taking such an effect on me because I'm feeling better. And then I went in to I met a friend in there. He was a therapist. He was an art therapist named Art. His parents were very cliche. And he was a Korean fella. He wore glasses, and he wore Hawaiian shirts every day. Like a champ, like he was in Hawaii every day. He was just coming there like, hey, it's Hawaii, but not really, you know. And he'd come in and he would teach you different forms of art. And I was a sketch artist my whole life. That is to say, I sketched things from a kid. I wasn't I didn't get paid for sketch artistry. I don't want to lie to you, all right? But I did draw since I was in kindergarten, and I would create I have hundreds of sketchbooks from my childhood and my adolescence. But I was drawing terrifying things. Angry, terrifying, mean, scary things. And he told me, that's all your subconscious, and that's all your pain. And it's good to get it out, but you know what's even better? Creating beautiful art that makes other people go, wow. Because that will also affect your brain, and that will also change your life in a good way. And it was the first time in years that I started drawing beautiful things. And it had an effect on me. So I'm doing all these things, and I'm getting better, and I get into my first halfway home. But let's back up. Before that, this is really, I'll tell you this, is my favorite story. Some of you have heard it, but I'm going to say it anyway. This is my favorite story, all right? Young man, he's 19 years old, Filipino, Spanish kid. He comes in on a gurney. He's catatonic. He can't move and he can't talk in that third psych ward stay. It was so sad. I had been starting to feel better, and he couldn't even talk and he couldn't even move. And every day they'd bring him to breakfast, and they'd bring him to lunch, and they'd bring him to dinner, and he'd sit there and they'd put his tray filled with food on the table. And an hour later, untouched, they would take it away like that was okay. I went to him, I tried to feed him, it didn't work. So I understood their plight. It wasn't easy for those nurses and staff, I get it. But I went to him, I thought, okay, I'm feeling better. What can I do to try to make this kid laugh, try to make him come out of his catatonia? And he's sitting there, and he's not moving every day. I'm talking to him breakfast, I'm talking to him lunch, talking to him dinner, I'm talking. He was a hell of a listener. But one day this kid looks up like this from staring at the food, and he goes, geez, man, you talk too much. Leave me alone. I jumped out of my chair. I did like this happy dance like that, which I get to do because they restructured my back with metal so I could walk again. I did that. And I heard clapping, and music was playing in the background of my mind. It's like a movie, and it was amazing. And he started talking. He's talking. He's very angry with me, so I leave the room, you know. Well, this kid, you guys, this kid was so special. He was 19, and you know why he was special? Because anywhere between 15 and 22 people would come to see him every day in a psych ward. That's unheard of. 15 to 22 people, that is no exaggeration. It was either 15 up to 22. His family came from all over San Francisco and the Bay Area every day to be there at different visiting hours. They came there to show this young man that they had his back no matter what he did, no matter the fact that he was in there for an overdose on methamphetamines and another drug. They were there. And when they couldn't all get in at the same time to see him, because you're only allowed 2 people at a time, they would rotate like a band, you know, and they would put their hands on the wired glass, you know, the terrifying prison-looking wired glass, and when he was not catatonic, he'd put his hand on the other side. I often saw tears coming down his eyes, but he knew they loved him. The numeric majority of every psych ward I've ever been, numeric majority of patients in every psych ward I've ever been, I hate that word patients, I don't like consumers either, we are not shoppers at Target. We are citizens of hope trying to find healing and recovery. That's who we are. And they'd come in, and then the rest of them had to stay in the waiting area. This tiny waiting area next to the elevator. Other families are coming in like, can you move, please? And it was beautiful. But the numeric majority of patients in every psych ward I've been have had no one to come see them at all. No one? I had a few people, a select few people, that came every psych ward stay. I was lucky. And you know what? I started to fall in love with this family. At the same time, I'm so jovial in the psych ward, which sounds really weird, but I'm so jovial in the psych ward that I go to my case manager and I say, Janet, you know, can I do something for the hospital? Can I do something positive for the hospital? You know, like can you give me a job? And she goes, you want to volunteer for the psych ward you're staying in? I said, yeah, that sounds like a great idea. And she goes, no! That's highly unethical and probably illegal, and that's not going to happen. And I said, well, can I have a hug? And she said, no. And I said, well, 8-second hugs release endorphins in the brain that make you feel better. And she said, leave me alone. Well, I asked her again. She said no. But then the best thing that could have happened happened. Jenna went on vacation. And I came up to the nurse's station the next day, and the new case manager was there, and I'd heard about this one. She was a certified hippie. She was from the 1960s, man, and she was out there. She had salt and pepper hair out to here, like it was wild, untamed. And she had a lay of flowers around her neck, like she was Hawaii. And she had flower in her ear, and she wore tie-dye shirts. Oh, she said they were different shirts. It was the same damn shirt. And I said to her, you know, I really would like to do something for the hospital. Oh, yeah, okay. That sounds like a lovely idea. What can we have you do? And this was a moment in time. I had planned the timing. Nobody else was at the nurse's station. And she goes back, and she's looking around for a job to give me, and she grabs a giant green binder, and she walks over here, and you are not going to like this. She says, I know what you can do. You can file these. Patient binders. HIPAA! Just do it alphabetically and don't look at the details. All right, I got a job. I did it alphabetically, guys. Come on, I didn't look at most of the details. I did not. I filed the binders, all like 20 of them. All right, and I asked for my next position, and she goes, I know what you can do. You can clean out the giveaway clothes closet for when people leave the hospital, they have something to wear. Because I'm wearing a hospital gown, hospital pants, and hospital slippers, and that wasn't fly. And I walked in the closet, and I cleaned the closet, I boxed, I binned, I labeled everything. I hung up when we had hangers, and I realized very soon thereafter, after trying a few things on, oh, the men's stuff fit me. And one day, I walk out of that closet. Effectively, I come out of the closet with a Ralph Lauren double-breasted polo suit and a 70s yellow flared collar like a gangster who owned the place. And I walk up to the nurse's station, and I see a clipboard. I go, I like clipboards. I grab the clipboard, I grab a notebook, I grab a pen, and I'm making official statements on this clipboard. I have got Leonardo the Ninja Turtle drawing, and he is looking good. Real official. And who do I see walk in but Pat Hines? Pat Hines, the pragmatic, pessimistic, stone-faced man, the man void of most emotion in my life. He's a beautiful human being, but he's a tough guy. Played ice hockey with no mask as the goalie. I just think that's a bad idea. Anyway, and my father, he has no peripheral vision, so he's standing there, and he's talking to this lady. He goes, I'd like to see my son Kevin, please. Very proper. And the woman looks at him and goes, And he turns, and you know what he said. Kevin, what the hell are you doing? And I said, Dad, I work here now. And he looked at her, and he goes, what? What? Like little John the Rapper, like what? And he's looking at me, and he's so angry, and he's yelling and screaming. He's like, I want to see the manager. And she's like, sir, this ain't a hotel. And he's like, just get me the head nurse. And that's it. I lost it, and I said, that's it. No more Pat Hines. I didn't think they were going to listen to me. They kicked him out. Like I actually worked there. Like I was running the place. I felt so bad later. I feel bad now. My dad and I, we've laughed about it. You know, I mean, I sit with him, and I laugh, and he looks at me angrily, but progress has been made. Now he nods his head a little bit, you know. And anyway, he leaves, and then the next day I'm wearing like a pink polo shirt, khaki cargo shorts, and sandals from the giveaway clothes closet, and they fit me, and they were brand new right out the box. It was great. And I'm standing there with my clipboard, finishing Leonardo, and making the morning, afternoon visiting hour announcements on the PA system, and I did all the announcements, lunch, breakfast, dinner, visiting hours, like group. It was great. Basically, I ran the place, and I'm making this afternoon visiting hour announcement, and I'm rhyming it because that's way more efficient, and I get a tap on my left shoulder, and there she was. Her name was Margaret, and I was done. I looked into those almond eyes, and I said to myself, I'm going to marry her. I quickly said, do not tell her that yet. It's a bit early. And she looks at me and she says, excuse me, do you work here? But she said it kind of loud, and all of the nurses' station is filled to the brim with people. And they're all looking at me like, what is this jackass going to say? And I looked at them, and I was like, oh, you better be quiet or I'll talk about the binders. Shh. Shh. I know HIPAA laws. Shh. Shh. I know my rights. And she says to me, I'm looking for my cousin. His name is. It was that kid. And this was her first time visiting. I said, Madam, right this way. And I put my hand on the small of her back and her elbow, and I glided her there. Which is totally creepy and weird, ladies. I don't know why I did it. And I got her there, and the kid sees me, and I duck out in the hallway because I don't want him to see me. He doesn't like me. And the kid, he's in there, and she goes, oh my gosh, your nursing staff is so nice. And she pointed at the guy that just walked out the door. Me. And he goes, that guy? At the top of the stairs, that guy jumps off bridges. Don't talk to that guy. And I ran in there, and I said, excuse me, it was one bridge. Plural, that's ridiculous. She came out, she said, you mean they let them run loose around here? She'd never been in a place like this. And she comes out, she goes, why'd you lie to me? I said, I didn't lie to you. I am a volunteer, 100%. I happen to also be a patient. Anyway, the kid gets out of the hospital first. I get out after. I go to my halfway home, 30 days probation, got to follow the program or else you're in trouble. And I get my first Friday and weekend off. Who do I call? Margaret. I had to fight that cousin of hers to get her number, but I got the number, and I called Margaret. I said, look, all I need is one date, just one. And she said, that's all you're getting. It's okay. And we go out, to this restaurant, and you don't order. They look at you and they judge you and they order for you. It's San Francisco. And they gave her a small plate and got me a plate. I got the food all over myself. They put on my side of the table uncracked lobster, a bunch of marinara sauce, a bed of spaghetti. It was a mess. I got lemon in her eye, like a stream just kept flying in right. She's crying, mascara's going down her face. I spilled hot butter from my plate. I tipped the plate with my shaky hand. I was so nervous. The butter flies. It drops onto her chest between her blouse. She screams. The couple next to us is like from 1920, and the lady goes, "Miss, do I need to call someone? Who are you going to call? The Ghostbusters? It's a date. It's going south. Leave us alone." "Margaret, I'm so sorry." I'm a gentleman. I grab my napkin, and I reach over. Doing this on a first date. Not a good plan, fellas. And she looks at me, she goes, "What are you doing?" "I don't know, I have no idea what I'm doing." We go back to the apartment. She goes, "Kevin, we're going to the roof." I said, "Are you gonna throw me over?" We get to the roof, we lay down these yoga mats. "What are we doing here?" I said to myself. And she turns to me and she says, "Kevin, if we stare at that moon for the rest of the night, ain't nothing else can go wrong." She's saying I have a chance. Yes. This June we'll be 10 years married. And that's why that's my favorite story. I don't tell you that to get applause. I tell you so you understand. It's a story of hope. And it doesn't mean we're all going to have that magical love that everyone wants. That's not what it means. It means that just because you are going through hell today, it doesn't mean you're not going to have one hell of a beautiful tomorrow. Ladies and gentlemen, yesterday is history. Tomorrow is a mystery, but today is a gift. That is why they call it the present. Master Mouse from Kung Fu Panda said that. All right? All right? Before he said it, the man Babatunde Olatunji said it first. Yesterday is history, tomorrow is a mystery, today is a gift. Let us always and forever cherish this present. Thank you from the bottom of my heart. Thank you.